Please start.
Okay, ma'am. Good evening, everyone. A very warm welcome to you all to today's ISA National Postgraduate Online class. We are honored to have such a distinguished gathering of postgraduate students, esteemed faculty members, and experts from across the country joining us today. Before we commence, let us invoke the blessing of Ma Saraswati, the goddess of wisdom and knowledge, by playing Saraswati Vandana. With the blessing of Ma Saraswati, let us now begin today's academic session. I, Dr. Pratibha, Assistant Professor, Integral Institute of Medical Science and Research, is your screen coordinator for today's class. Now I warmly welcome Dr. Sukhminder Singh Bajwa, sir, Honorary Secretary, ISA National, and request sir to kindly say a few words. Over to you, sir.
Thank you, Dr. Pratibha. I welcome everyone in this class. I can see my GC colleague, Dr. Ashish Diwan sir, is also here. So it's so nice that the senior people are attending the classes. That's a good sign of the success of these classes. Moreover, the topic for the today's class is the cleft lip and palate. I think this is one of the most clinically and theoretically challenging topic whenever you are in a postgraduate career, especially when you are first or second year, because that time you may not be knowing so many delicate intricacies which you have to learn over the next 2 years to emerge as a successful anesthesiologist while administering anesthesia to these patients. Apart from that, the airway management in this patient is very, very difficult. So many things are there, and so many specialties are actually involved into this one surgical entity, your anesthesia administration, then your airway management, and pediatric anesthesia. It's a very difficult and challenging topic, the cases, and you have to learn very, very carefully about each and every aspect of the anesthesia administration steps. And we have got one of the very renowned faculty of the country, Dr. Sona Dave and team. And the madam have got a huge hospital with so much of the surgical load every day. So I think we have chosen the best team to present this class rather. So I welcome you all to this class and I request Pratibha to take it over from here.
Thank you, sir, for your kind words. Moving ahead, I will take the privilege to introduce our distinguished speakers for today's class. Our presenter for today's class is Dr. Samiksha Habbu, a third year resident, Department of Anesthesia, TNMC, and BYL Nair Hospital, Mumbai. And also the moderator and esteemed faculty members of today's class, Dr. Dave ma'am, Sona Dave ma'am. Let me Dr. Dave ma'am is a professor of anesthesiology at TNMC and BYL Nair Charitable Hospital, Mumbai. She brings with her an impressive teaching experience of over 30 years in postgraduate teaching, and her areas of special interest include regional anesthesia, difficult airway management, and medical ethics. She is also a recognized teacher for the Regional Anesthesia Fellowship. Dr. Dave also holds prestigious position, including serving as a president of ISA Mumbai Metro branch. Her academic contributions are remarkable, with over 20 publications and 6 book chapters to her credit. We are truly privileged to have Dr. Sona Dave Madam with us today to share her expertise.
Thank you, Dr. Pratibha. Thank you, Dr. Pratibha.
Yes,
Good,
yes, ma'am.
good evening, everybody. I would like to thank ISA National, Dr. Sukhminder Bajwa, Dr. Manisha Katikar for giving me this opportunity today. I also would like to thank Dr. Madhuri Kurdi and Dr. Nishan Sayer for seamlessly coordinating this webinar today. And of course, Dr. Pratibha, who is the screen coordinator today. I now invite Dr. Samiksha to take over for today's presentation.
Ma'am, first of all, I would also like to introduce our next faculty speaker, Dr. Ashish Mali, sir. Sir is an additional professor of anesthesiology, TNMC and Nair Charitable Hospital, Mumbai. He is also affiliated with Mumbai Maharashtra University of Health Science. Dr. Male has over 14 years of postgraduate teaching experience. His areas of special interest include neuroanesthesia and obstetric anesthesia. He has significantly contributed to the research with 10 publications to his credit. We are delighted to have Sir and Madam with us today. And today's topic is anesthesia for cleft lip and cleft palate, a thorough understanding of which leads to a very good outcome. The perioperative management carries a very uh, uh, it has carried a very good outcome. Now I would like to inform the audience about the class protocol. The the audience are requested to remain muted during the session and kindly keep your videos turned off. Please type your queries in the chat box, or you can raise your hands and they will be taken up at the suitable time. I now invite our respected faculty to kindly introduce their students and take over the session. Over to you, ma'am.
Thank you, Dr. Pratibha. Sorry for interrupting you in between. Again, thanks to Dr. Bajwa and Dr. Manisha Katikar, Madam, and Dr. Madhuri Kurdi and Dr. Nishan Saab, who are today here. And thanks, Pratibha. I would like to now invite Dr. Samiksha Habu, a third-year resident at TNMC and BYL Nair Hospital, who is going to present the case on cleft lip palate today. Over to you, Samiksha.
Thank you very much, ma'am. Very good evening. Today I'll be presenting a case of 11-month-old male child brought by mother with complaints of defect in the roof of mouth since birth and regurgitation of fluids and food through nose while feeding. Baby also has repeated ear and respiratory tract infection in the past 11 months. And mother gives history that the pediatrician noticed defect in the left upper lip at the time of birth, and she observed that the child had difficulty suckling and swallowing during feeding. The mother also gives history that the milk is regurgitating through the nose during feeding. And now the baby was given feeds with express breast milk to feeder while the holding baby in upright position. Baby also had a history of recurrent episodes of cold and running nose, which was managed conservatively and did not require any hospitalizations. A mother does not give any history of ear discharge, sweating during feeding, bluish discoloration of skin, or any skeletal abnormalities in the baby, and there is no history of similar deformities in the family, parents, or the siblings. Obstetric history and the birth history. Baby is the first-born child out of non-consanguineous marriage. Mother has received regular ANC checkups and received iron and folic acid supplementations throughout. There is no history of exposure to radiation, teratogenic drugs, alcohol consumption, or diabetes mellitus in the mother. And first trimester scan did not show any congenital abnormalities in the baby. Birth history. It's a baby is a full-term normal vaginally born baby weighing 2.5 kgs who cried immediately after birth and did not require any NICU admissions. Developmentally, baby has achieved that baby can sit without support, can speak monosyllables, can has achieved a unidextrous reach, recognizes mother, and has a stranger anxiety. Immunization history. Baby is immunized with BCG, OPV, hepatitis B, pentavalent, and IPV, all doses up to date. Nutritionally, baby is being fed with mother's express breast milk and liquids while holding the baby in the upright position using feeder, and there is regurgitation of fluids present. Past surgical history, baby is an operated case of cleft lip repair at the age of 3 months under general anesthesia without any perioperative complications. On general physical examination, baby is alert, playful, and active. There is scar mark over the left upper lip. There is no pallor, icterus, cyanosis, clubbing, no lymphadenopathy or edema seen. Sacral area examination appears normal. There are no obvious skeletal deformities seen. Anthropometrically, baby is 70 centimeter in length, weighing 10.5 kgs. Head circumference is 44 centimeters. And there is no micrognathia, retrognathia, macroglossia, or microstomia in the baby. Oral cavity palpated with the little finger shows complete left-sided cleft palate. On vital examination, baby's temperature is 38.4 degree Fahrenheit. Pulse rate is 112 beats per minute, regular in rhythm, normal in volume and character. Respiratory rate is 24 cycles per minute. On systemic examination, cardiovascular system, first and second heart sounds are heard normal, no added murmurs heard. On respiratory system examination, bilateral air entry is equal on both sides and clear, no added sounds are heard. On palpation of the abdomen, it's soft, non-tender, and there was no organomegaly. And CNS examination, baby is alert, playful, and the spine appears to be normal. From above history and examination, we can say that the baby is 11-month-old child, status post left-sided cleft lip repair with no associated congenital anomalies and with no evidence of active upper respiratory tract infection, now posted for cleft palate repair. These are the investigations noted of the baby.
Thank you, Samiksha. Now you said this is a congenital condition, right? So can you briefly tell me something about the embryology of the development of the lip and palate?
Yes, ma'am. Lip and palate development occurs the 4 to 10 weeks of gestation age, ma'am. This is a diagram briefly showing development of a face.
We can't see your diagram.
Samiksha, show the diagram. Yeah, that's better.
Ma'am, upper lip develops from the first. It starts with the formation of somatoectoderm, which then forms the frontonasal process and maxillary processes. Frontonasal process then divides into median and lateral frontonasal processes. Both the medial nasal processes and the maxillary processes fuse together in the midline to form upper lip. And lower lip is formed by fusion of in the midline of both the mandibular processes, ma'am. And cleft palate, primary palate is formed from the extension of the frontonasal process, whereas the secondary palate is formed from the palatal processes, extension of maxillary process. These two palatal processes, as shown in the diagram, they fuse in the midline from anterior to posterior fashion, and the free end of septum fuses with the medial end of the palatal process, ma'am.
So basically, the development is complete by which week?
Ma'am, development completes by 10 to 12 weeks of gestation.
By 10 to 12 weeks, it is complete. So the lip develops basically from the medial nasal and the maxillary processes, and the palatal plates this thing form the palate, especially the secondary palate. The primary palate is formed by the same medial nasal process and the maxillary process. Can you tell me briefly about the types of clefts?
Ma'am, cleft lip, from the types, cleft lip can be divided as unilateral, bilateral, or it can also be divided as complete or incomplete. Complete cleft lip is the
Can you show?
in complete cleft lip, the cleft extends into the nostril, ma'am, and then incomplete there is just defect in the upper lip. Palate can be divided as primary cleft palate and secondary cleft palate based on the incisive foramina, ma'am. Primary cleft palate is also called pre-palatal because it is present in anterior to incisive foramina, and secondary cleft palate is present posterior to incisive foramina. It's also called as post-palatal cleft. There is also third type of cleft palate, ma'am, which has only bony defect, but the mucous membrane over it is intact. So it is called submucosal cleft palate.
Samiksha,
Yes, sir.
you have told about the embryology of the cleft, but can you just tell me the predisposing factors which can lead to this? Which you can get a clue from the ANC period or the history? Can you tell me?
Yes, sir. From history, if the increased maternal or paternal age or maternal exposure in the first trimester.
Do you have some slides regarding that? So it will be a better picture. Good.
Factors like maternal factors like and in the first trimester to maternal smoking, alcohol consumption, pure maternal nutrition, especially folic acid deficiency, and maternal infections like torch infection, and use of teratogenic medications like anticonvulsants like eptoin, or anti-cancer drugs like methotrexate and isotretinoins. All these have the correlations, and also exposure to radiation. And during embryological development, malposition of the tongue or mandible development, which will if they obstruct the formation fusion of the both palatal processes in the midline, that can also lead to cleft palate formations.
Can you diagnose this antenatally?
Yes, ma'am. We can diagnose the cleft lip from about 18 to 20 weeks of antenatal scan. But in isolated cleft palate is difficult to diagnose, ma'am, because it is situated inside the oral cavity. But the presence of signs like micrognathia or polyhydramnios in the mother will indicate towards us that there might be a presence of cleft palate. So we should look for the cleft palate. We should suspect that the baby might be born with cleft palate if such signs are present.
Basically, cleft lip palate may be a feature of nearly 200 syndromes. So if it is diagnosed antenatally, it initiates the search for some other syndromes in the baby which can be picked up at an earlier age.
Yes.
Okay. Samiksha, you have told that regarding the embryology, regarding the predisposing factors, and regarding the diagnosis in the ANC period. But can you tell are there some congenital anomalies associated with them, which can be a problem for the anesthesiologist?
Yes, sir. As ma'am said, there are more than 200 congenital anomalies associated with this cleft lip and palate. But the more important ones to us are Pierre-Robin syndrome, Richard-Collins syndrome, hemifacial microsomia,
just wait, Samiksha. You don't just mention. Tell me the basic difference between Pierre-Robin and Trickers, because these are the main things which can trouble us.
Yes, sir. In Pierre-Robin syndrome, we see micrognathia and glossoptysis, sir. In these Pierre-Robin syndrome babies, as the age advances, the intubation becomes more easier because of development of mandible. So it is advisable for us to wait for a few months till the mandible develops. Whereas in Richard-Collins syndrome, so it is other way around. There is micrognathia and maxillary hypoplasia. So as the age of the baby advances, the intubation becomes more and more difficult compared to comparatively. So we would like to take up the baby for procedure early ages.
What is this velocardiofacial syndrome?
Ma'am, velocardiofacial syndrome is usually velopharyngeal incompetence associated with cardiac congenital anomalies, and the more anesthetically important feature is that we see laryngeal and tracheal anomalies in the baby. So we should be preoperatively assess the baby about if the baby has laryngeal or anomalies and optimize accordingly.
Any other syndromes?
Ma'am, we also see Down syndrome, Klippel-Feil syndrome, and fetal alcohol syndrome.
Show it on the slide, na?
Ma'am, anesthetic concerns in Down syndrome would be first thing is they have more risk of more chances of having cardiac congenital diseases. and there is a high chance of atlantoaxial subluxation or instability. So during intubation or during giving head extension during position of the baby, we should be cautiously giving the extension, or the baby might have paraplegia or paraparesis.
Now you have described all the problems. What are the basic anesthesia concerns you are worried about in such babies?
Ma'am, for cleft palate babies, the main key concerns would be, first thing, these are pediatric patients, ma'am. And because of the cleft lip, baby will not be able to take feed properly. So they are more prone to malnutrition. And the recurrent regurgitation and micro aspirations will lead to recurrent respiratory tract infections. And moreover, we have discussed that baby are more associated with congenital anomalies, cardiac or any other anomalies we should look forward. And these usually come with difficult airway. That is also a very challenging part to us, and we share the airway with the surgeons. That becomes challenging part. And the most important one is that in post-operative period, these babies are at high risk of post-operative airway obstruction. These are my main anesthetic concern when to look for this patient.
Basically, these patients are pediatric patients, and as we all know, pediatric patients are not miniature adults. They have their own set of problems related to airways and other developmental factors. Also, because of this, children cannot be breastfed, and there is continuous regurgitation. There is high chances of respiratory infection in these patients, and they come with a bundle of other congenital cardiac anomalies, which we have already seen.
Okay. Samiksha,
Yes, sir.
You are telling regarding all the anesthesia concerns. So are you going to give all the patients which are going to come on table, or are there some guidelines with the help of which we can tell the surgeon that what will be better, means when to take, when not to take? So are there some rules, nomenclature? So can you just put light on that?
Yes, sir. We usually follow rule of 10 to be on the safer side in the
What is the
pre-anesthetic.
nomenclature of that? Who has done that?
Sir, it is called Killer's rule of 10. It
Good.
is for both cleft lip and cleft palate. For cleft lip, rule of 10 says that baby's age should be more than 10 weeks. Baby's weight should be more than 10 pounds. That is corresponds to 4.5 kgs. And baby's hemoglobin should be more than 10 gram %. And the baby's total leukocyte count should be less than 10,000 per cubic millimeter. Whereas for the cleft palate procedure, the age of the baby becomes more than 10 months of age, and the weight becomes 10 kgs, whereas rest two criteria remain the same.
Good.
Why are all these criteria set? But
Ma'am, to be on the to grossly assess the babies preoperatively, and to assess the perioperative morbidities in the babies, ma'am. To assess
why
the
this age limit 3 to 6 weeks and 9 to 18 months? Is there any this thing?
Yes, ma'am.
Importance?
We repair cleft lip before cleft palate, ma'am. Cleft lip can be repaired as early as 3 to 6 weeks, because one first thing is it is cosmetically better for the baby, and early repair of the cleft lip leads to proper attachment of the baby to the mother's breast and improves the feeding of the baby,
Yeah.
and improves the nutrition. We repair cleft palate later, which is comparatively a major procedure compared to cleft lip, ma'am. So the building up of the nutrition helps baby to face the next major surgery coming. And
What
there is
happens if
also
it is
a
operated early? It hampers the facial development also. So that is why the ideal time should be between 9 and 18 months and not before that. Okay, how will you do the preoperative assessment of this patient?
Ma'am, after thorough history and examination, I would like to investigate the baby. I would like to have a hemogram to look for hemoglobin and total leukocyte count, ma'am. Hemoglobin, because as we have discussed, the baby is more prone for malnutrition because of all the various reasons, and is also prone for infection. So I'd like to look for the hemoglobin and the total leukocyte count, which will also affect in the post-operative wound healing of the baby. And I would like to have a coagulation profile done for this child, as it is posted for cleft palate and has the increased risk of bleeding. And we have discussed that the baby has a recurrent regurgitation and microaspirations leading to lower respiratory tract infections repeatedly, and might have pneumonia history. So I would like to have a chest X-ray to see for any post-infective changes, and a 2D echo to be done to see for any cardiac congenital anomalies which are associated with all syndromic associations. And then USG abdomen to look for renal anomalies like renal agenesis or ureteric duplication and all we can see in the USG abdomen. And I would like to have a pediatric consultation assessment done for to rule out any syndromic associations in the baby.
Yes, Samiksha. You told that the patient may have recurrent URTIs, that is upper respiratory tract infection. So are you going to defer every time the patient comes with URTI, or what are you going to do? Because the patient will have recurrent URTIs. So the patient can never come on the table. So can you do, because you have to operate also the case?
Sir, first, if the baby has come with running nose, I would like to assess the baby if the baby has purulent nasal discharge, fever, or raised leukocyte count. On our auscultator finding, I would like to see if their baby has a wheeze. If any of these signs and symptoms are present, I would like to defer this case for another 4 to 6 weeks preferably. If not, we can go ahead with the procedure without a delay.
Yes, even fever and wheeze can be a problem. So better we postpone the case for about 3 to 6 weeks. Good.
Samiksha, any special preparations in the OT you would like to do before taking up this case?
Yes, ma'am. As it is a pediatric patient, and we might end up in difficult airway situation. First, I would like to in the morning of the procedure, I would like to inform parent or legal guardian process of general anesthesia and related complication to the parents and obtain the informed consent and confirm the NBM hours of the baby. And I would like to tell surgeons to pre-secure a IV on the priorly.
Yeah, can you show us the cart or something which you're telling? That will be a bit good.
And as it is a pediatric patient, I would like to have a OT to be ready with warmer or warming blankets ready. And difficult airway card should always be kept ready, as we have many associations which have difficult airway situation. I would like to have different size of mask, different sports, different size of plates, and stillate, bougie, LMAs, nasopharyngeal and oropharyngeal aids ready in the OT before taking the patient inside.
Anything special? Would you like to have pediatric fiber optic and help of some surgeons?
Sir, as my baby has already undergone a procedure at the 3 months of age, and there is no history of any complications or airway related complications during the procedure. So I would not like to have it inside the OT, but I would like to have it in the vicinity. If just in case if I need it, I'll be able to access it.
Which cases you might require fiber optic or awake intubation or tracheostomy? Any specific?
If baby has a severe retrognathia, such as in Pierre-Robin syndrome and Kitcher-Collins syndrome, if there is severe retrognathia and we are suspecting the baby we will have a difficult airway, that time I would like to have a fiber optic FOB ready inside the OT, and I will also call a ENT surgeon standby to give for an emergency tracheostomy just in case we are not able to secure the airway.
Okay. Samiksha, you told that you would like to secure the intravenous line, that is the IV line before. But I think everyone is not fortunate that way to take an IV line before. So how are you going to go about the securing IV line if the patient doesn't have, and how are you going to pre-medicate this patient? Because the patient might be outside the OT, we have to take the patient inside. Separation anxiety or other anxieties must be there. So how are you going to go about that?
If I don't have an IV line in the patient, we can give preoperative, in the preoperative area, we can give sedation to the child by either using midazolam or ketamine. Ketamine can be given IM 3 to 5 mg. Per orally it can be given up to 5 to 10 mg per kg, along with the glycopyrrolate of 0.01 mg per kg. And once the baby is asleep, we can take the child inside.
How much time for midazolam? How much time before midazolam?
Sir, if we give orally, it takes around 30 to 40 minutes to act. So we should wait for that much amount of time. If we give IM, it takes 10 to 15 minutes to act. So we should wait for that time. And once the baby is asleep, we can take the baby inside, and we should prime the circuit priorly before taking the baby inside. And we should I will do a inhalational steal induction by incremental doses of sevoflurane. And once we achieve the MAC of around 0.7 to 0.8 with the inhalational agent, then we can try to secure an IV. Once the IV is in place, we can go ahead with the intravenous induction.
Any
me
other
something
things which
about
will
the
be given? Sorry, ma'am. Anything others you can give instead of ketamine and midazolam?
Sir,
Some
we can
syrup?
also give dexmedetomidine, that is 0.5 to 1 microgram per kg, or we can give syrup Finargan or chloral hydrate syrup.
Can you give through the intranasal route in these cases, or
Sir, intranasal midazolam and dexmedetomidine can be given, sir, but as these patients are very cranky and the absorption is also not certain, so I'd like to avoid the giving
yes?
intranasal
Also,
sedation.
anatomical problems are there, so that may be a hazardous. Okay, good.
okay, now you sedated the child. Can you tell me something about the induction of this child?
Yes, ma'am. Once we induce the baby, we with the propofol and this thing. Once I can confirm that I can mask ventilate the baby, I would like to give long acting muscle relaxant like atracurium, and into secure the airway. Do a laryngoscopy using Miller's straight #2 blade and secure the airway with South Pole RAE tube. And once the tube is inside, once the airway is secured, I would like to fix the tube in the midline and on the mandible and do a proper throat packing.
Why Miller's blade, Samiksha?
Sir, in children, tongue is comparatively larger and the larynx is situated in the higher up position, and there is also floppy epiglottis. So Miller's straight blade gives us better control over all these things, overcome these problems.
Okay.
What is the full form of RAE tube?
Ma'am, it is ring Adair Elvin tube. It is a preformed tube, ma'am, which has a bend. Which the bend comes at the level of mandible and the angle, ma'am. So it's used.
Would you prefer a cuffed or a non-cuffed tube?
Ma'am, I would like to have a cuff tube in this patient.
Okay.
Why?
Any special laryngoscope? Yes,
Uh,
answer, madam.
Ma'am, cuff tube because during this procedure, there is first thing is we share airway with the surgeon. So and the surgeons operate in the oral cavity and they give little head extension during the procedure. If the tube is not cupped, there are chances the tube might just we might end up in accidental extubation. So I would like to have a cuff tube.
Basically, cuffed tube provides a better seal compared to an uncuffed tube, less chance of accidental extubation. Okay, and any other tube you can use. Supposing you don't have a preformed RAE tube, which other tube you can use?
Ma'am, we can use tubes like flexometallic cuff tubes and micro cuff tubes are available. And we can also use normal uncuffed tube, but we should do a proper throat pack.
You cannot use normal micro cuff tubes because this procedure cannot be done with them. Any reason? Why
Sorry,
do
ma'am?
you require these preformed tubes?
Ma'am, these preformed tubes, they have a bend which comes in the center, ma'am, and the surgeons apply a Dingman mouth gag. This Dingman mouth gag has a slot for the tube. So this RAE tube comes exactly in the center and it can be passed through the slot which is provided in the Dingman's mouth gag. So I would like to have
Okay. Any special laryngoscope you want to use in case difficulty?
Sir, if we are expecting it to be a difficult airway preoperatively, first I would like to use a video laryngoscope, CMAT #2 blade.
Okay. You told that you are going to fix the tube in the center. Why so normally fix the tube on one side? Then why we are fixing in the center?
Sir, for cleft lip repair, we fix it in the center because surgeons use it as a landmark for symmetry of the face and cosmetically repair the lip. And for the cleft palate, we fix it in the center because the Dingman's mouth gag has a slot in the center to pass through the tube so that the tube can be passed and the tube is placed away from the surgeon's field.
Okay. You told regarding the throat pack. Sometimes the surgeon tells that we want to pack the throat. So are you okay or would you like to do scopy and see? What about that?
Sir, once we fix the tube and after applying Dingman mouth gag, sometimes surgeons can also pack the throat. But once the throat is completely packed, I would like to do a scopy and see if the ula is free and they have packed the throat properly or not. That I would like to confirm once.
Good. and also to see the resistance. Okay, good.
What about this thing? What are the problems because of the cleft palate or lip with laryngoscopy? Can you show this thing pictures?
Ma'am, during cleft palate, when there is a cleft palate during laryngoscopy, there are high chances that the scope blade gets hinged in between the cleft, ma'am. So it will cause a trauma. To avoid this situation, we can use a wet roller, gauze, or holster to pack the area and then do a laryngoscopy to avoid trauma.
After this, the surgeon gives some position. What is the position and what are their concerns because of that?
Ma'am, after this thing, surgeons usually give an extension, ma'am, and few surgeons sometimes may give extreme extension that might cause accidental extubation or endobronchial migration of the tube inside, causing endobronchial intubation. So we should be careful during giving positioning of the baby.
This
And,
especially show in cases like Down syndrome and all, where there are chances of atlantoaxial dislocation. So you should be very careful while giving the position to these children under anesthesia. Anything the surgeon applies after this?
Ma'am, after positioning, surgeons apply Dingman's mouth gag, which might compress the tube during fixation. So, if we are hand ventilating the baby, we'll come to know if with the compliance of the bag or the tight bag. And if we can see the airway pressures on the monitor, we should be watchful towards the monitor to increase towards increased airway pressures to see if the mouth gag has compressed the tube or not.
Any other important thing you'll tell the surgeon? You'll ask the surgeon to release the gag every 1 hourly so that there is not excessive pressure and increase in tongue edema post-operatively. So every 1 hourly, you can ask the surgeon to release the mouth gag for some time.
Okay, Samiksha, now the gag has been applied. Now, what is the next step surgeon is going to do, which can cause lots of problems?
Sir, usually after applying mouth gag, surgeons give local infiltration over the incision area with adrenalized normal saline. Sir, if the if depth is not adequate or if we have a hypoxia, I would like to avoid hypoxia and hypercarbia during this period because it might land up us in tachycardia, tachyarrhythmias, and tachyarrhythmias. Sir. So we should be keeping the baby with inadequate depth of anesthesia during infiltration. And I would also like to tell fellow surgeon, or we should be cautious that the maximum dose of adrenaline should not exceed, that is 5 micrograms per kg out of 1 in 2 lakh solution. So during this time, we should be cautious about these things.
Anything from your side to avoid so that the patient doesn't become in a risk factor?
So we could maintain adequate depth of anesthesia and avoid hypercarbia and hypoxia during this period. So
what about the inhalation agents?
Sir,
if we are using halothane, then are you more worried, or are you more worried when we are using sevoflurane?
Sir, in olden days, halothane was used, which used to cause severe ventricular tachycardia during this period. But now we are using sevoflurane, the chances of it are very less. But we should be cautious as they are infiltrating the adrenaline.
Good.
Samiksha, can you tell me some important intraoperative concerns?
Ma'am, my main intraoperative concern would be accidental extubation or intubation, endobronchial intubation, that is tube misplacement during the procedure. So we should be very watchful throughout the procedure and keep the difficult airway cart ready throughout the procedure. We should not dismantle the cart because we might have to re-intubate the child if there is accidental extubation. And if there is excessive bleeding in palatal repairs, we should be, I would like to preferably replace blood with the blood in 1:1 ratio. And we should avoid as I said, during adrenaline infiltration, we should be watchful towards the tachycardia and tachyarrhythmias.
Okay, what about pain management in these patients?
Ma'am, I would like to give multimodal analgesia for this patient. Non-opioid analgesia like paracetamol can be given in doses of 10 to 15 milligrams per kg. Either can be given IV or suppository towards the end of the procedure. I would like to give opioid analgesia, that is fentanyl 1 microgram per kg IV at the time of induction. And if needed, we can give 0.5 micrograms per kg of bolus dosages intraoperatively. And we can also give regional blocks like for cleft lip repair, we give intraorbital block. It can be given in two ways, either intraorally or extraorally. And for cleft palate repair, we give suprazygomatic maxillary block, greater palatine, lesser palatine, and nasopalatine blocks.
Can you show?
Yes. This is the diagram. This is the diagram showing intraorbital nerve block. It can be given intraoral or extraoral. Intraoral technique, first we palpate the canine in the first premolar, and 25 to 27 gauge needle is inserted into the buccal mucosa, directed upwards and outwards as shown in the diagram. And we palpate the foramina with the other finger on the outside and direct the needle, and then the local anesthetic is deposited. For extra oral method, we draw an imaginary line from the midpoint of the pupil and then horizontal line from the L of the nose. And there we palpate and insert a needle at the depth of less than 1 centimeter. We can deposit a local anesthetic.
For palate, what?
And for palate repair, we give suprazygomatic maxillary block, ma'am. In this, the 25 or 27 gauge needle is inserted perpendicular at the line joining between superior ridge of zygomatic process and posterior canthal process. Then local anesthetic is deposited at less than 1 centimeter depth after a negative aspiration for blood.
This is basically an advanced block, so should be given by an experienced person only. And you can use USG guided. USG guidance should be used. And remember to locate the internal maxillary artery. So do not go very deep into the fossa.
Yes,
any other blocks?
Ma'am, we can give greater and lesser palatine block. These are given at the level of first and second premolar. And greater palatine fossa is palpated, and block is given in between the lateral palatal border and the alveolar ring. And lesser palatine block is given just proximal to greater palatine block. And there is a diagram also showing nasopalatine block. It is given at the level of incisive foramina. After because from the incisive foramina vessels also arise, so we should always negative check back aspiration for the blood and then deposit the local anesthesia.
Okay. Samiksha, what special care you have to take while giving the blocks? Have you to think about the maximum dose because
Yes,
something?
sir, because sometimes surgeons also give instead of in our institute, usually surgeons give an adrenalized normal saline, sir. But some in some places, surgeons also use sensorcaine or lignocaine with adrenaline. So we should always ask the surgeon how much dose they have given, and we should not cross the toxic dose combined with blocks and the local infiltration.
Okay, good. So now we are done with the case. We are perioperative, intraoperative, everything is done. So we are coming to the end of the case.
Samiksha, can you tell me about the monitoring? Just 1 minute.
Yes, ma'am.
Intraoperative monitoring.
Ma'am, intraoperatively, I would like to have all ASS standard monitors like pulse oximetry, ECG, non-invasive BP, and the temperature monitoring and the capnography monitoring, ma'am.
One more thing, you can use the precordial stethoscope continuously to hear the breath sounds. Okay.
Okay. Samiksha? Samiksha, can you hear me?
Yes, sir.
Now we are done, almost done with the case. Now is the time for extubation or starting the reversal. So how are you going to go about that? Because this is a very important phase. Not only the extubation, but also the post-operative phase. So how are you going to go about that?
Sir, first, before extubating the child, once the surgeons are done and the gag all, everything is removed, first we inspect the pharynx. First we remove the throat pack and announce it loudly in the OT so that we are sure that the throat pack is out. And then we inspect the pharynx for any fresh bleeding. If there is any fresh bleed or a clot or any debris, we should suction and remove them out. And we should extubate the child only when they are fully awake and all airway reflexes have returned to normal. And throughout the procedure, difficult airway cards should be kept ready. And immediately after extubation, we should keep the baby in prone or in the recovery position.
Which position is better?
Sir, prone is the best position to keep. If not possible, at least recovery or lateral position should be given.
Why do you say prone position?
Ma'am, because cleft palate repair, surgeons usually leave many raw areas in the palate and oral cavity. So there is so much secretions and blood will be pooling out. So in the prone position, blood pools out, hence minimizing the chance of aspiration and aspiration.
Basically, they create mucoperiosteal flaps and which leaves a lot of raw area which are bound to bleed, and it takes nearly 5 to 6 days for it to completely heal. So to help prevent in drainage of blood and better maintenance of the airway, prone position is sometimes advantageous, but it may not always be possible in the recovery. So in that case, at least the parent should be told to keep the child in the lateral position.
Okay, but if there is a tongue fall or something, how to go about that? The patient might have some obstruction. So are you going to take any care, tell the surgeon, or what you are going to do?
Sir, to prevent the tongue fall, including we can keep the baby in the lateral and prone position. We can also do is ask the surgeon to take a tongue stitch loosely, which works in two ways. Either by pulling the tongue out mechanically, it also helps as a stimulant to respiration, so the baby will not go into post-operative apnea.
What about the airways?
Sir, in post-operative period, immediately in the recovery room, it is not advisable to use nasopharyngeal or oropharyngeal airways because there is so much raw area, and the sutures which surgeon has just now taken can get disrupted. So, just in case die-hard emergency, we can use nasopharyngeal airways, but not the oral airways.
Okay.
What will you look for before extubation? Anything else? One is bleeding. You should look for any tongue edema. We have instances where you have to re-intubate the child. So always look for tongue edema. And many times the surgeon uses small gel foams which they keep in the raw area. So you have to inquire about that also before extubation. The surgeon has to be present at the time of extubation. Even the nurse remains washed up with the equipment all ready at the time of extubation. Any role of USG for this cleft lip palate surgeries?
Ma'am, as we have discussed, there is role in giving regional blocks. USG guided blocks give a better result, and we can avoid the vascular injuries during vascular injection during the USG guided blocks. And as we have discussed, these babies are more associated with congenital anomalies and difficult airway situations. So we can also assess airway with USG, ma'am, in preoperative area.
So pediatric focus will come into picture with this. That will help you, right?
Yes.
I saw your cart. You told that you will be keeping difficult intubation and ventilation things ready. I saw an LMA there. So can you just tell in brief how the LMA is going to help, or what may be the role of LMA in cleft lip or palate?
Sir, one thing is LMA can be used as a rescue device when we are not able to intubate the child or there is difficulty. We can just put a LMA as a rescue device, and it can also be used as a aid to intubation. That is, intubating LMA can be used to aid the intubation, or the LMA can also be used as a sole ventilation purpose also. Sir.
Yeah, but that is not recommended. Just tell me if you want to pass an LMA in a patient who is post-operatively operated for cleft palate. So is it recommended, or will you pass LMA, or what you are going to? If you want to pass an LMA, any care?
Sir, in the first few weeks till the suture line is healed, we should avoid using LMAs as much as possible. But even in the post-operative period, we say that lateral rotation of LMAs in the oral cavity is not advisable. So we'd like to avoid using an LMA in post-operative.
Supposing the patient has been operated, can you use nasopharyngeal airways for these patients? Operated cleft palates and all?
Ma'am, if the surgeon has not done pharyngoplasty and closed the area, we can use nasopharyngeal airway, but Only in emergency situations we should.
No, if the patient comes later on, you can use a nasopharyngeal airway, provided a pharyngoplasty has not been done in that patient. Okay. What if this patient intraoperatively suddenly develops tachycardia?
Ma'am, first we would like to know the cause of tachycardia. The most common causes we come across in daily routine practices, one is inadequate depth of anesthesia, inadequate analgesia, and adrenaline infiltration by the surgeons, and full bladder can also lead in tachycardia. And there is hypercarbia can also lead to tachycardia. First, I'll see the cause and then treat.
Blood loss
So first,
also.
blood loss. So first rule out the common causes. Yeah, first try to rule out the common causes and treat that. You told me in the history that patient was operated for cleft lip at the 3 months of age, right? And now he's
Yes.
posted for cleft palate, right? So why we do not combine both of them? Ultimately, we have to repair both, basically cleft lip as well as cleft palate. So why not to repair it together? Why at one time lip, then the palate, or palate first lip? So means 2 times anesthesia. Why in a kid? So why?
So first thing is we should not repair the cleft palate early, because as it might cause the scarring of the growth plate. And the way in early period, cleft lip should be repaired prior to cleft palate. Comparatively, cleft lip is a minor procedure which a baby can withstand, and it is cosmetically better when operated early. And with once we repair the cleft, the latchment of the baby is good, and baby can take better feeds, and which improves the nutrition of the baby. Once the baby's nutrition is improved, the baby becomes ready for the next comparatively major surgery, and we can also utilize this time gap to optimize the associated congenital anomalies in the baby. So we repair cleft palate late and will leap earlier.
If the baby has a cleft lip and you want to increase the nutrition, how do you advise the feeding for this child?
Means
Ma'am,
madam is telling that he is not operated, but we want to increase the nutrition part till he gets operated for palate or lips. So how are you going to go about that?
Ma'am, we can use spoon. We can give spoon feeding to the baby, or specialized Palade feeds can be given. Or there are commercially available bottles like Heberman's bottle and Neat Johnson bottle, which are basically have a elongated nipple or Y-shaped nipple to help the baby create. These bottles will lead a less negative suction to feed the baby. So these can be used to feed the baby if lip and palate are not repaired.
Okay. You told about this, but you might have seen that the patients or the babies are very, very cranky. The main cause of being cranky is they are not that way fed, or they are nil by mouth. So how are you going to give the nil by mouth instructions? Because the baby is going to cry. So how are you going to do? Instruct the mother and regarding clear or any other fluids?
Sir, first breast milk should be given 4 hours prior to the procedure. Can be given up to 4 hours prior to the procedure, and any feed other than breast milk, such as cow feeds or formula feed, should be given 6 hours prior to the procedure. And clear liquids can be given up to 2 hours of the procedure. I will ask the mother to give if the baby is posted at morning 8 o'clock or 9 o'clock. I'll ask the mother to give clear liquids to the baby in the morning 6 or 7 o'clock. But that
Yeah,
way,
because
baby
it
will
is
get
physically not possible for the mother to get at 3 o'clock in the night. So she can give around 12 or 1, and then whenever required, the baby can be given clear fluids. Okay.
Any other history you will ask for to the mother, which you can point to certain thing where you will be careful during extubation?
Ma'am, during extubation, ma'am, I would like to ask the history of snoring or OSA history in the child to the mother if the baby snores in the sleep. If so, then we should extubate the child when the child is fully awake and all the airway reflexes have appeared with the awake extubation. And there are high chances that baby will have post-operative airway obstruction. As it is, the babies are at risk of post-operative airway obstruction, but this will augment it. So we should ask the history now.
History, one very important history, especially in pure Robbins and all, is suddenly the child becomes apneic during feeding. The child cannot take in the feeds because of OSA. The child becomes apneic during feeding. So this history is also very important. And these children with retrognathia may be tolerating, may be normal during their normal circumstances, but after post-extubation, they may suddenly develop severe airway obstruction. And they may require some period of post-operative ventilation before you can extubate them. What about fluid, Samiksha? You didn't say anything about fluid management intraoperatively.
Ma'am, intraoperatively, I would like to give balanced salt solution to the baby with using holiday Seger formula. That is, first 10 kgs we give 4 ml per kg of fluids. Then the next 10 kg we add 2 ml per kg, and later on we add 1 ml per kg. So accordingly, according to this formula, we give maintenance fluid in the perioperative period to the baby.
Can I ask last some questions, Samiksha?
Yes,
You asked regarding the family history. So how it will be important family history means? Are you going to ask family history means any parents related, if one or both? How is that? Because the next child may have high chances. So you have to instruct the parents also.
Sir,
So
if
any
both the
ratio?
parents are affected with the defect, the baby being born with the cleft lip or palate are around 10%. Sir. And if the only one parent has, the baby being born with the defect is 3%. So, and there are high chances that the sibling will also have a cleft lip and or palate defect. So that history we should take.
And just some last question from my side. That is, you told that you will be giving some pre-medications for separation anxiety. So, at what age or what time the separation anxiety or a stranger's anxiety? So, because these are two different. So, what is the age? What are the months where you will be anticipating anxieties?
Sir, separation anxiety, stranger anxiety starts by 3 to 6 weeks, and the stranger anxiety starts at 9 months. So, as my baby is 11-month old, the baby will have stranger anxiety.
Around 6 to 8 months. That is not 9. Around 6 to 8. That's okay.
Can these children come for repeated surgeries after this?
Huh?
Can these patients come for other surgeries after this?
Yes, ma'am. If the palatal depth, recurrent cleft or remnant cleft opening is there, if it is not closed properly, these babies can come for the repeat surgeries.
Yeah, they can come later for alveolar grafts or rhinoplasties at much later ages. So you have to remember.
Again, yeah, scar revision can be one of the things because they are corrected in the pediatric group. So as they grow up, the scar becomes more. So they can come for scar revision when they become adults. These are the things.
I think Dr. Pratibha.
Dr. Samiksha, there is a question in the chat box. Can you repeat those special names of those special bottles for feeding again?
Ma'am, bottles like Neat Johnson and Haberman's bottles, ma'am. And feeding the Palate feed is it's a cup like thing which is specially designed to feed the
Samiksha, can you spell it out for them to understand better?
Ma'am, Palade is Padalai. Neat Johnson is Need, Neat Johnson's. Haberman's is Habermans.
Thank you, Dr. Samiksha.
There are some obturator devices also available in our dental, this thing, which they can use for feeding the child.
They are basically plates, palatal plates, which the dental gives for that.
In case of both lip and palate, lip is repaired first, followed by palate. Can we show the multiple choice questions now, madam or Pratibha?
Yes, please go ahead, ma'am, with the MCQs.
First question is, what is the first choice of endotracheal tube for the cleft palate repair babies? Option A is North Pole, option B is South Pole tube, option C is flexometallic, and option D is microcuff tube.
I think everyone is getting it right.
Most of the audience is opting for option B.
Pratibha, you tell us when to show the next slide.
Ma'am, 45 seconds for each question. You go ahead.
Okay.
B and D, maximum responses are for B and D.
Oh, D is also coming.
I don't know whether South Pole microcup tubes are available or no, but South Pole is the correct answer. B.
I think we should proceed to the next.
Yeah, go ahead with the next MCQ, Samiksha.
What is the preferred measure to take post-operatively to prevent the post-operative tongue fall in the baby? Option A is oral airway, option B is nasal airway, option C is tongue tie, and option D is LMA. Sorry. Option LMA is option D. It's by mistakenly came as B. Sorry.
Dr. Pratibha, see what is the maximum response?
Maximum response is C. I think
That is tongue tie.
yes, time is up. Yes, ma'am. Now you can answer, Samiksha, Dr. Samiksha.
That's the correct answer.
Okay. So we'll proceed to the next MCQ.
Third question is, what is the best position for the baby to keep in a post-operative period? Option A is supine position, B is lateral position, C recovery position, and D is prone position.
Okay, we are getting responses. Mostly it is D and some are C also. D. Okay, Dr. Samiksha, kindly answer.
Ma'am,
Mostly
option D
the
is right
response is
answer. We
D.
can keep the baby in lateral and recovery position, but the most preferred one is prone position. If we cannot prone the baby,
Oh.
then we can as well give recovery or lateral position. But answer is option D, prone position.
Okay, hope our audiences got the answer. So next MCQ, please.
Fourth option is, which among the following is or are risk factors for cleft lip and palate in antenatal period exposure? Option A is alcohol consumption. Option B is smoking. Option C is anti-epileptics. Option D is all of the above.
Okay, we are getting the responses, mostly D. Let's wait for some time, then we'll reveal the answer. D. C. Again C. Okay, Dr. Samiksha, now kindly give the answer.
All of the above have the risk factor. So option D is the correct answer.
Okay. I think the next.
Moving on to the next question.
Yes.
Cleft palate should be corrected at what age? 9 to 12 days of life, 9 to 12 weeks of life, 9 to 12 months, and 9 to 12 years.
Okay, we are getting responses, mostly B. B. Again B. Yes, Dr. Samiksha, now kindly answer this.
Option B is right answer, 9 to 12 months. That is we have
Okay, and
discussed.
next MCQ.
What is the challenging part in a airway management of a baby coming with only cleft lip? That is difficult laryngoscopy, difficult intubation, difficult mask ventilation, and all of the above.
We are
Baby with only
getting
cleft
mixed
lip.
responses. Okay. B, mostly it's a mixed response between B and D. So,
Whenever I think we give all of the above, there is a confusion.
yes. It's B, B again. Again, B. Again, B. Yes, Dr. Samiksha, kindly answer.
For only cleft lip babies, there is difficulty in mainly mask ventilating the child, as there will be leak in the mask. So
Okay, the
B is
correct
the correct
answer
answer.
is B. Okay. The next MCQ.
What is the maximum dose of adrenaline which can be given used in the local infiltration? Option A is 50 micrograms per kg. Option B is 1 milligram per kg. Option C is 5 micrograms per kg. Option D is 1 microgram per kg dose.
So this is also, we are getting a mixed response between C and D. C, D, D. Okay, let's wait for some more answers. D, C. So it's a mixed response between C and D. So yes, kindly
C
answer.
is the correct answer because we consider 5 micrograms per kg as a limiting dose.
Okay. So C is the answer, right?
Yeah.
Yes.
Okay. So we'll proceed to the next question.
Next, which of the following statement for a child posted for cleft palate surgery are correct? First sentence is blood grouping and cross matching is not necessary for this child, and 10 ml per kg of PCV should be issued before starting the procedure. Third statement is preferably blood loss should be replaced with blood in 1:1 ratio. Fourth statement is cross matched blood of 10 ml per kg should be kept ready in the blood bank. Option A or option 1 and 3 are correct. Option B is sentences, statements 3 and 4 are correct. Option C is second and fourth statements are correct. Option D is all are correct. Option E is all are not correct.
Okay, we are getting answers. Mostly option B they are choosing. B, B. Again, it's a B. B. Okay, let's get the answer from Dr. Samiksha. Samiksha?
Ma'am, option B is right answer because we would like to, we will want a blood grouping and cross matching for this child because we would like to transfuse if there is a blood loss. But we will not want it to be issued before the procedure. But I would like to cross match and keep a 10 ml per kg of blood in the blood bank, not in the OT ready before the procedure starts. And the blood should be replaced preferably with the blood. So statements 3 and 4 are correct in this question.
So the option B is correct. So
Option
all
B
are
is correct.
getting. Yes, all have done
Next
it
question
correct.
is
Yeah.
infraorbital nerve is a branch of. Option A is mandibular nerve. Option D is facial. Option B is facial nerve. Option C is nasociliary nerve, and option D is maxillary branch of trigeminal nerve. I'm really sorry for this mistake. Option B, facial nerve is option B, not D. Please.
Okay, here is a correction. Option facial nerve is then option B, not D. So we are getting mixed response again between C and D. C, D, C, D. Okay, let's see. D, D. A, one A is also coming. So Dr. Samiksha, kindly give the answer.
Ma'am, option D is right answer. As infraorbital nerve is a second branch of trigeminal nerve, that is maxillary nerve.
Okay, option D is correct. So we'll proceed to the next MCQ now.
Which is the most common presentation in the most common presentation. Option A is left-sided cleft palate. Option B is right-sided cleft palate. Option C is bilateral cleft lip. Option D is bilateral cleft palate.
So we are getting responses mainly A. Everyone is going with A only. So let's wait for some seconds and then we'll answer. A. Okay. A. Kindly give the answer, Dr. Samiksha. Mostly the responses are A only.
Yes, ma'am. Option answer is A, ma'am. Left-sided cleft palate is more common among all the presentations which we get.
Okay. Yes. Thank you. So I think the MCQs are over.
I thank our dear Sona ma'am, Ashish sir, and esteemed faculty present here for giving me an opportunity to present a case in such a huge platform. Thank you very much, ma'am.
Audiences can ask some other questions also if they have regarding today's class. We would like to take all those. So we are getting thank you responses. So I think there is not much questions. I think you have presented it very well. Okay, one question has come. Which analgesic should be used post-operative and intraoperative period?
In post-operative period, intraoperatively during induction we use opioid analgesic like fentanyl. Instead we use 1 microgram per kg and intermittent bolus doses of fentanyl. Towards the end of the procedure, we usually use 10 to 15 milligrams per kg of paracetamol, either IV or it can also be used as a suppository. Can also the same paracetamol can be continued in QID doses in post-operative period. Or if we are giving regional blocks, it will last for few hours so that the baby will not have pain in the post-operative.
With the blocks, paracetamol is generally enough in the post-operative.
Okay. Hope Dr. Deepak has got his answer. So what is the best time to remove tongue tie if taken post-operatively?
Post-operative period, once we know the baby is fully awake and taking adequate respiration is regular and fully awake and responding, that time we can remove the tongue stitch. Once we rule out the airway obstruction causes is no more a risk factor, we can remove
I
the
think
tongue
at least 1 day should be waited for till we remove, because that is the critical period. So I think 1 day the tie should be kept.
Okay, sir. In old days, PVC ET tube, south pole, oxygen, nitrous, and ether with spontaneous ventilation was used. Okay, doctor.
Yes, I think that time Oxford tube were used, but now they are being banned. They are not being used, and I think spontaneous we are not using currently.
Okay, thank
I
you.
think so. With the fire, there is a high chance of risk of fire also. Anyway, we don't use ether nowadays.
Oh.
Actually we have advanced to such a level now. We are not talking about the 3 decades back anesthesia.
Yeah.
The modern day anesthesia full of advancements, full of medical litigations, and so many things, and patient safety being the primary concern in the
Priority.
present day world now, from all aspects. I think those were the days. I think we have advanced, and at least they provided a platform to work upon the innovations and advancements.
We have learned on that. Yes.
Yeah, actually, they were the learning, what you call the foundation.
Without monitors, also we have done these cases.
Yeah. With a test,
Precordial stethoscope was
precordial stethoscope and holding the pulse even that sometimes, and sometimes holding the tube with the fingers, no? With the pen holding manner, the surgeon is doing the surgery and we used to hold the tube.
And the airway pressures were in our hands. It was not on the machines.
The fingers were the best respiratory dynamics manometer at that time. With the JR circuit on in your hand, that's the best way to monitor. But I think with the newer gadgets, still care has to be exercised for all type of surgeries, whether it's a cleft lip, palate, because even cleft lip cannot be, seen in a lighter surgery than the palate, because the tube dislodgement, so many things can keep on happening. You just can't rely upon
And
the
they do
electronic.
happen repeatedly. They have happened in our this thing also where I've reintubated.
And sometimes the electronic media devices, gadgets, they take a little longer time to detect those mishaps, whereas the clinical acumen of yours and your vigil can detect within 4 seconds, rather than waiting another 30, 40 seconds, something to appear on the screen, something like that.
I think no more questions left. So, okay, ma'am.
So,
Yes, madam.
Yeah. Ma'am, congratulations for giving a very beautiful presentation on the cleft lip and palate.
Thank you,
And
madam.
it inevitably comes as a short case in the PG practical exams. Just to complete the list, like Dr. Samiksha was telling, you asked the question, a role of ultrasonography in
Yes, madam. Actually,
cleft
there are a
palate. Yeah. So I think even a calculation of the endotracheal tube
tube diameter.
size, but
Yeah.
that is still not very practical, but maybe she can
Maybe,
add
yes.
that to the list.
Yes.
And regarding the old tubes, I think Murray sir told about the Oxford tube, na? So that reminds me of the Palate tube also,
Yes.
because it has a larger diameter below, and because of which you can't push it inside beyond the larynx.
Oxford tube had a bevel which was facing posteriorly.
Yes, yes,
So
yes,
it used to abut against the wall if there was too much of extension.
yes. And Samiksha, the importance of post-operative monitoring, especially for airway obstruction. I'm remembering a case when several years back, when there was no post-operative care unit in a hospital, and the cleft palate surgery had been done for a very healthy baby. And I was just there, and I saw the baby was totally cyanosed, and it had gone into arrest. And we rushed the baby inside and intubated, but it could not be resuscitated. So there are high chances of airway obstruction occurring post-op. I think you've already told us a mixture post-operative
Yes.
airway obstruction can occur. So what are the possible causes of airway obstruction post-operatively?
Possible causes are, first thing is large tongue fall, ma'am.
Yeah.
And after surgery,
The tongue gets
airway
displaced into posteriorly.
posteriorly.
Mhm.
And after cleft palate repair, the airway space reduces.
Excellent.
And that reduces the airway area to accommodate the tongue, which
Yes.
causes airway obstruction. And
Yes.
also, as the ma'am told, there are fresh areas which continuously blood trickles. So there is chance that the blood clot might get into the airway, and then baby will get a airway obstruction.
Yes. Then there can be increased oral secretions. Then there can be chances of laryngeal edema also following endotracheal intubation. And there can be sometimes a throat pack if you've forgotten. That chances are there. And they say that once the surgery is done for cleft palate, there'll be some kind of lymphatic obstruction also, which can cause edema of uh, that area, palate, causing obstruction. Excellent.
Thank you.
See, this edema part, I'm telling you, it depends upon your surgical skills of the surgeons, how beautifully they have dissected the planes, because any edema develops, that the typical Bernoulli's theorem, that the decrease of the airway resistance increase almost 4 times to the square. So that's what happening when you do the dissection. You may not be able to get the edema immediately post-operative, maybe another 1 hour. But the tissue edema, whether it's a lymphatics or it's a venous circulation from that particular area, it gets hampered. And when it starts increasing in the post-op ward, you can always have typical develop that narrowing of the passage for the breathing. And the already sedated patient with a compromised, airway aperture, the opening of the airway. You may have a laryngeal or you may have a pharyngeal, you may have oropharyngeal edema, anywhere. The pathway gets obstructed. I think Here comes the role of that PACU, the post anesthesia care unit, specially dedicated to the pediatric surgery, where you have got all the airway equipment ready. As told by Dr. Madhuri, that patient could not be resuscitated because these patients have a very low FRC. They get desaturated within a minute or 2 minutes, and the brain hypoxia is easy to develop. The time we take the patient for resuscitation, we may not be able to resuscitate. So it's always ideal that as good as awakening position, or even if you have a good monitors in your institution, they are best to see the awareness, the wakefulness of these patients. The more they are awake, the more chances are that the airway obstruction will be less in these patients. But still, the first 2 hours, I think, very, very crucial if the soft tissue part is dissected to a larger extent. And especially the age is less because already the aperture is very small, it gets further reduced. These are the golden principle taught by our teachers. They still hold valid whatever the whether we go for the ultrasound assessment or the MRI assessment or the CT assessment, the neck of the tube size or whatever. But the golden principles will hold the principles for always to take care in these type of patients. So, madam, it's just wait for it. We have got something to say. At least thank you from the ISA National to the dedicated people who presented this class. My screen is visible to you, ma'am? Sona Dave,
Yes,
madam?
sir. Yes, sir. Thank you very much, sir.
So, ma'am, they're really
Thank you very
delighted.
much, Bajwa sir, and all that. Thank you, Sona madam, for giving me a chance.
Yeah, your certificate is also there, sir. Don't worry about it.
Thank you,
So,
sir.
Sona Dave, madam, being the team leader, and she agreed upon a very short notice for this class. And thank you, madam, for this wonderful presentation. Very basic class. The short cases, the theory question, everything comes on this thing. We are thankful to you for this
Thank you
presentation,
very much, sir.
for being the team. And Shish Mali sir, for thank you to you also for taking care to prepare Samiksha for this class. I know you must have taken extra effort to
Yes.
prepare
No, no, sir,
precisely.
it's a part of it.
Though it's visible, become visible when you are moderating the session. It become visible how much pain you have taken to prepare
And
the.
Ashish and Samiksha have worked together quite a lot.
It was visible, very much visible that they were communicating with each other. So thank you, Dr. Ashish, for being the moderator of this class. And Samiksha, you were confident, at least you did not do any blunder and did not do anything silly while answering the questions. So good student. So as we always traditionally says, you have passed your pre-final. So Dr. Sona Dave will be giving you a gold medal when you are appearing for the final examination. If you do well, if you do well like this, there
Thank you
also.
for your kind words. So thank you very much.
Yeah. And Pratibha, good anchoring. So it was expected that you will be a good anchor. Know your confidence also. The person from my alma mater, so she was very much confident about this presentation. Thank you, Dr. Pratibha, for being the screen coordinator for this class.
Thank you, sir. I think
Thank you,
Thank you,
Sound madam.
Pratibha.
And,
the presentation was really very valuable for our postgraduate students, both for their exam perspective and also for their professional life. And thank you so much, I want to say thanks to every faculty for putting their inputs, Bajwa sir, Madhuri ma'am, and also Sona ma'am and Ashish sir for their valuable inputs.
and a special thank to Dr. Madhuri and Dr. Nishant for preparing the technical
Yes,
aspect of this
and
class.
Yes,
yes,
ma'am.
I
Thank you
hope.
very much, madam.
Thank you,
Sir.
madam.
I just want to listen from Dr. Rasis Devan, who sat throughout the class, our GC member. So, Dr. Rasis, your the word of wisdom for everyone. Unmute, sir, unmute yourself. Okay, sorry. Just let me make it clear. Just wait. Now you can do, sir. Unmute yourself.
Thank you so much, Dr. Bajwa. Indeed, it was a very good discussion, excellent presentation, and more important was the interaction done at the end of every point you discuss, right from assessment to the post-operative analgesia. This is probably is working very well because every time somebody will have a cleft palate case, a short case or long case in the examination. So it is a very useful tips to the postgraduate students appearing in the examination. And I like the comment Dr. Bajwa made I'm from the era before 40 years when I had an extensive experience of palate tube when we use the Oxford or Coles tube, which are rubber tubes with Y-shaped connection. And that was the era we started getting halothane. Maybe Sona, you must have experienced those things in past. Only thing which I made a modification was timing of the surgery. We started doing operating these cases not early in the morning as what the textbook said to us. We started operating after 10, 11, 12 o'clock, depending on the age and the time we want to keep them fasting. So it was very good for the mothers to feed them in the morning, like they don't have to wake up in the night. And that probably worked best. And we always monitor the blood sugar after the baby is induced. We check normally we do it routinely. So that was the only modification I made of changing the time after 10, 11, or 12 o'clock in the morning hours. And we didn't have post-operative recovery uh, places to monitor them critically. So we had to keep them with us for about half an hour or so. And the tongue ties we were doing those days also, which we were keeping till evening. Once the child is fully alert, taking feeds, we were used to remove it by evening.
Yeah, that's
That's it,
really,
Dr. Bajwa.
yeah, great
Thank
words. I think these are the experiences speaking, and I think we have advanced to such a good level.
That's
The
right.
amalgamation and the modifications in our techniques, as well as the advent of the newer drugs. Now we having a TIVA again, and the World Conference on TIVA coming up. So in every class, I have to advertise that we are having a World Conference at Chandigarh, where we are accepting all the TIVA and non-TIVA categories paper also for all the PG students to showcase their talent in that particular. I think cleft lip palate and other cases where TIVA can be done is a part of that airway management workshop also. TIVA in a difficult airway management. So I think it's a wonderful novel concepts are coming up. We will learn more from the stalwarts of those people. So welcome you all to the TIVA workshop, TIVA this one conference, World Seva, part with the ISA also, and Chandigarh 25th to 27 July. So Sonadave Madam, all are welcome from your institution. We will be expecting more than 25 registration and at least 10 presentations. So you can go ahead with that. It will be a day to remember for the participation in TIVA, World TIVA. Yeah. So I think nothing more. So we have to say now, the end of the class, we always end by saying long live ISA.